Okay. So so how are we going to do the pathology? We're gonna do the pathology in the, okay, 1 second. So I hope I'm audible now. If you could share my voice and see the screen properly, type yes on the chat box. If you could share my voice and see the screen properly, type yes on the chat box. So speaking about the pathology, as I said, pathology is a hidden giant, people. So with this, you can able to answer most of your, most of your questions, such as your medicine and surgery questions can also be answered. So speaking about it, how are we going to do the pathology? So, pathology has a three major division. The number one is going to be your general pathology and hematology, general path, hemat, and systemic path. And systemic path. So speaking about that, we have to do it in a short term with the more one. So how are we going to do is, we give more focus on these two, general and the hematology, and we give less focus on the systemic pathology, because that will be covered in your surgery and medicine. For example, Crohn's disease, ulcerative colitis, Down syndrome, nephrotic syndrome, nephritic syndrome, everything needs to be discussed in the medicine too, right? So we will cover the pathology point over the medicine too. So in this area, or in this pathology section, the main focus of main area of interest is your general and hematology. But we do the systemic, but only we do whatever essential part we do. Clear about that? So shall I proceed to the general pathology? Okay, much better. So speaking about that, the very first topic of interest in the general pathology is your cell injury. Cell injury and adaptations. As we know, the cellular adaptation comes under the first area of interest. So we have 4 types of cellular adaptation. What are the 4 types of cellular adaptation, people? Hypertrophy, hyperplasia, metaplasia, and atrophy. Hypertrophy, hyperplasia, metaplasia, and atrophy. Apart from that, there are certain other modifications such as dysplasia and aplasia. We will discuss that after this. Okay, what is meant by hypertrophy? Increase in cell size, people. Increase in cell size is so called as hypertrophy. So how does the cell is increasing its size? One is via the gene activation. Activation of genes could result in protein synthesis, and more protein, more production of organelle, more production of organelle, size of the cell will increase. Size of the cell will increase. Then you have that hyperplasia. So hypertrophy is increase in cell size, while hyperplasia is increase in cell number. While hyperplasia is increase in cell number. You have to know that. Okay. So speaking about that hyperplasia, increase in cell number. So the hyperplasia could be of physiological and pathological. One such a classical example of your physiological hyperplasia is pregnancy. And one such a classical example for your pathological hyperplasia is progress to dysplasia and cancer. Okay, most pathological hyperplasia may progress to dysplasia and cancer. Very, very important exception. The exception is BPH, because it can never progress into the cancer one. It can never progress into cancer. Okay, then we are having a metaplasia. So metaplasia means change, people. So change of one cell type to the another one. Change of one cell type to the another one. One such a classical example is your Barrett esophagus, and the most common change is your columnar to squamous change. What is the most common changes in your metaplasia? That is your columnar to squamous change. And atrophy, exactly opposite to hypertrophy. That means decrease in cell size and number. Decrease in cell size and number due to the decrease in the protein synthesis and increase in protein degradation. Increase in protein degradation. So how does it increases the protein degradation? Via ubiquitin proteasome pathway, that we studied that in the later. Okay, via ubiquitin proteasome pathway, it can increases the protein degradation and produces the cell shrinkage. Okay, then you have a dysplasia, disordered cell growth. There won't be any proper order in the cell growth. Aplasia, failure of the cells produced during embryosis. Okay, yeah, failure of the cells produced during embryogenesis. Okay, so cellular adaptation, very simple. Increase in cell size, hypertrophy. Increase in cell number, hyperplasia. Change of one cell to another cell, metaplasia. Decrease in cell size and number, it is a atrophy. Disordered cell growth, dysplasia. failure of cells produced during embryogenesis, that is a aplasia. That is a aplasia. Pretty straight components. Yes or no? Okay. Now, speaking about the cell injury, what is the most common cause of cell injury? The most common cause is your hypoxia. Very, 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 very important MCQ people. What is the most common cause of cell injury? Hypoxia. And hypoxia could be of reversible and irreversible. Sorry, cell injury could be of reversible and irreversible. What is the mechanism behind the reversible cell injury, and what is the mechanism behind the irreversible cell injury? So both can result in the hypoxia. Most common cause is hypoxia. Hypoxia is most common cause of hypoxia is ischemia. So whenever the cell is having ischemia, ischemia leads to hypoxia. So whenever there is a oxygen is not working, as I said when I was taking an electron transport chain, cytochrome oxidase, which is a complex 4 of electron transport chain, totally depend on what? Complex 4 of electron transport chain totally depend on what? It is totally depend on your oxygen. Yes or no? Now lack of oxygen in the cell that could lead to. Now lack of oxygen in the cell that leads to what? Faster people. What is that? The lack of oxygen could lead to lack of activation of your cytochrome C. Am I right or wrong? Lack of activation of your cytochrome C, lack of activation of your cytochrome C, that in turn failure in the function of your complex 4 of electron transport chain. So whenever there is no complex 4 of electron transport chain is working, then there is no oxidative phosphorylation, no ATP synthesis. So absence of ATP synthesis will happen. The net result is absence of ATP synthesis, both reversible and irreversible. But what are the characteristic findings in the reversible and reversible cell injury? So lack of ATP, increased intracellular calcium level, activation of phospholipase. You will see the myelin figures. Very, 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 very important MCQ. And decrease in ATP synthesis could result in the blockade of your sodium-potassium ATPase because no ATP is available for exchange. So sodium and water will influx. And whenever the sodium and water is in flux, then what happened? Cell will undergo swelling, mitochondrium will undergo swelling, endoplasmic reticulum will undergo swelling. So cell swelling could result in cytoplasmic vacuole production. Mitochondrial swelling could result in small amorphous density. ER swelling could result in ribosomal detachment. And disaggregation of granules or fibrillar elements. Very, 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 very important MCQ. All of the following are the changes of your reversible cell injury except. So cytoplasmic vacuole formation, small amorphous densities, and ER swelling with ribosomal detachment and disaggregation of your granular or fibrillar elements, people. What are they? Disaggregation of your granular or fibrillar elements. All these things could produce a reversible cell injury. So ischemia, hypoxia, no complex 4 of electron transport chain, no complex 4 of electron transport chain, no ATP, no increased calcium, activation of phospholipase, and thereby producing a myelin figures. And lack of sodium potassium ATPase, water and the sodium will be influx, cell swelling, vacuole formation, mitochondrial swelling with small amorphous densities. Very, 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 very important MCQ. Small amorphous densities is seen in reversible, while large flocculent amorphous densities is seen in irreversible. That you will study that after this. Okay, you have to remember the difference. Then, now speaking about the irreversible cell injury, so ischemia to hypoxia to complex 4 is not working. When complex 4 of electron transport chain is not working, then lack of ATP synthesis. So lack of ATP synthesis could result in increased calcium level. So increased calcium level will activate 3 to 4 enzyme, people. Will activate 3 enzymes here. So first is your endonuclease. Second is your, I rather highlighted in the red color. So first is your endonuclease. Second is your protease. And third is your phospholipase. So decrease in the ATP production will cause increase in calcium. Increased calcium is producing what? 3 enzymes. What are they? One is your endonuclease, protease, and phospholipase. So endonuclease could result in nuclear damage. Endonuclease could result in the nuclear damage, so that you may see the characteristic appearance of your pycnosis, choriorexis, and choriolysis. Very, 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 very important characteristic appearance. Pycnosis, choriorexis, and choriolysis due to the endonuclease activation. So protease activation could result in the disintegration of your cellular architecture, and phospholipase activation could result in increase in cell membrane damage. You may see the myelin figure. You may see the myelin figure, and because of the cell membrane damage, you may see the large flocculent amorphous densities. Large flocculent amorphous densities. So very simple, people. So cell injury, most common causes hypoxia, could be reversible, irreversible. Both have a same mechanism till ATP production. What is the difference? In a reversible cell injury, only intracellular calcium will activate phospholipase, myelin figures will be formed. Then lack of ATP will block the sodium potassium ATPase, water and sodium will be influxed, and then you see the cellular swelling, mitochondrial swelling with the small amorphous density, and ER swelling with the ribosomal detachment and disaggregation of your granular or fibrillar element. Okay, then you have a irreversible one. Same ATP production decreases, a calcium will be increased. Increase in the calcium will activate three enzymes. What are they? Endonuclease, protease, and phospholipase. Phospholipase, you already know, myelin figures will be formed, and cellular membrane damage could result in the large flocculent amorphous density. Okay, and protease, cellular membrane disintegration or lack of your cellular membrane. And endonuclease, here comes the important part. Pycnosis, choriorexis, choriolysis. Pycnosis, choriorexis, and choriolysis. This is the important one you have to remember, people. Okay, in terms of your reversible and irreversible cell injury. So progressive reversible injury may convert into irreversible injury. Irreversible injury may undergo cell death. So cell death could be of either a necrosis or apoptosis, people. Okay, cell death could be of either a necrosis or apoptosis. So cellular killing is necrosis, cellular suicide is apoptosis. Cellular suicide is apoptosis. So what are the things you may see it in the necrosis and apoptosis? The table is very, 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 very important. Cell size will increases, and in the case of apoptosis, cellular shrinkage. Okay, in case of necrosis, increase in cell size, while in case of apoptosis, decrease in cell size. The nucleus will undergo the irreversible cell injury changes in necrosis, pycnosis, choriorexis, choriolysis. While apoptosis, it will form an intranucleosomal fragment. It will form a intranucleosomal fragment. Then plasma membrane will be disrupted in necrosis, will be intact in the apoptosis. Cellular contents will be leaked out of the cell in the case of necrosis, and it will be intact in the case of apoptosis. And inflammation can trigger necrosis, and inflammation cannot able to trigger apoptosis. So we will do the apoptosis part later. Now we talk about the necrosis. Speaking about the necrosis versus apoptosis, what are the basic things you have to know? Necrosis is kind of like killing the cell, while apoptosis is kind of like suicide cell. So suicide cell have any damage? No. So plasma membrane will be intact, and your cellular content will be intact, and nucleus will have an intranucleosomal fragment formation. And cell size, only the cell size will decrease. While in the case of your necrosis, it is a damage we are doing. So plasma membrane will be disrupted, cellular content will be leaked out, and nucleus will undergo pycnosis, choriorexis, choriolysis, and the cell will be swelling due to the lack of sodium potassium ATPase. Sodium and water influx will be happening, and in turn causes a cellular swelling. So cellular swelling will happen in necrosis. So far clear about the necrosis versus apoptosis. So we talked about the reversible cell injury, we talked about irreversible cell injury, and we talked about the structural differences in your necrosis and apoptosis. Now we talk about the types of necrosis and the types of apoptosis. We finish off your cell injury. Okay, clear about that? Now speaking about the types of necrosis, coagulative necrosis, liquefative necrosis, and there are certain special types like a caseous, fat, and fibrinoid one. Caseous, fat, and fibrinoid one. So speaking about the coagulative necrosis, what is a coagulative necrosis? It is a most common pattern of necrosis which is seen in the solid organ, like your heart, liver, kidney, spleen, everywhere. And it is coagulative necrosis is due to the protein denaturization. Okay, protein denaturization. And then you have a liquefative necrosis, which is a lysosomal permeability. release of enzymes, which is seen in the bacterial infections, and liquefactive is seen in brain infarction. And caseous necrosis, which is associated with the Mycobacterium tuberculosis. So whenever you see tuberculosis, immediately choose caseous necrosis. Tuberculosis, caseous necrosis. Brain infarction, liquefactive necrosis. Solid organ, coagulative necrosis. You have to remember that. And caseous necrosis is a combination of your coagulative and liquefactive necrosis. Caseous necrosis is a combination of your coagulative and liquefactive necrosis, people. You should not miss it. Then you have a fat necrosis. Fat necrosis contains adipose tissue, which is caused by your lipase activation, where you see the chalky white deposition, people. Where you see the chalky white deposition. So here are the chalky white depositions. You may see here, this is your fat necrosis. This is your fat necrosis. So these are the one you have to remember. And then you have a fibrinoid necrosis. So speaking about the fibrinoid necrosis, where you see the antigen antibody deposition in your blood vessel, antigen antibody deposition in your blood vessel, and it is seen in vasculitis and malignant hypertension. So what type of necrosis is seen in the brain? What type of necrosis is seen in the brain, people? It is a liquefactive necrosis. What type of necrosis is seen in vasculitis patient? What type of necrosis is seen in vasculitis patient? Fibrinoid necrosis. What type of necrosis is seen in the heart? Myocardial infarction, that is a coagulative necrosis. What type of necrosis you may see it in the Mycobacterium tuberculosis? That is a caseous necrosis. You have to remember that. This is a gross picture of your caseous necrosis. This is a cross picture of your caseous necrosis. And this is a gross picture of your myelin figures. So this is a histological picture of your myelin figures. And then you have this liquefactive necrosis. And then you have this coagulative necrosis. These are the types. You may see it here as a histological images, which was added here. Now, speaking about that apoptosis. Speaking about that apoptosis, people. So speaking of apoptosis, what is the earliest change you may see it in the apoptosis? That is your cell shrinkage. Very important MCQ. Cell shrinkage. And the most characteristic feature is chromatin condensation. Most characteristic feature is your chromatin condensation. And what is the hallmark? The hallmark is caspase activation. Another important MCQ. Whatever I am quoting here are the straight MCQs that has been asked in FMGE that you should not forget. Okay, what is the earliest change? Cell shrinkage. And then most characteristic feature, chromatin condensation. Hallmark, that is a caspase activation. Then you have appearance of endonuclease-induced intranucleosomal damage in gel electrophoresis. You may see the step-ladder pattern and gel electrophoresis. Okay, what type of apoptotic pattern you may see it in the gel electrophoresis, which is an endonuclease-induced intranucleosomal damage that appears as a step-ladder pattern. That appears as a step-ladder pattern, people. Very important MCQ. Okay, so this is all about the apoptosis straight questions. Now, speaking about the mechanism, we are having an intrinsic and extrinsic pathway. We are having an intrinsic and extrinsic pathway. So we first talk about the intrinsic, then we talk about the extrinsic, people. So speaking about the intrinsic pathway, whenever the cell is undergoing a stress, the stress will activate an apoptotic protein, and then it will inhibit the anti-apoptotic protein. So what is the anti-apoptotic protein that the stress will inhibit? Inhibition of BCL2 or MCL1. Inhibition of BCL2 or MCL1. And stimulation of Bax/Bak protein. Stimulation of Bax/Bak. So both can increase as mitochondrial permeability. Whenever mitochondrial permeability has been increased, then what happened to cytochrome C? It leaks out, right? Yes or no? Because it is placed in the intermembranous space of your mitochondria. Now, whenever the anti-apoptotic protein has been inhibited and apoptotic protein has been activated, that is the time where the mitochondria will show the increased permeability, where cytochrome C will leak out. Normally it won't, but in the increase, due to the increase in the mitochondrial permeability, it leaks out and then it binds with the APAF, apoptotic activation factor. It will bind with APAF, that is your apoptotic activation factor, and APAF activation could, cytochrome C apoptotic activation factor binding could stimulate your caspase 9, which stimulates your caspase 9, which is the initiator caspase in your intrinsic pathway. So what is the intrinsic pathway? Stress activates backs or back, increase in mitochondrial permeability, cytochrome C will leaks out, cytochrome C will bind with apoptotic activation factor and in turn initiate the caspase 9. So which in turn causes the initiator caspase, and initiator caspase will stimulate the executioner caspase of 367 and in turn activates endonuclease, where you may see the nuclear damage and chromatin condensation, Then you have the extrinsic pathway. Where you may see the FAS or FAS combines with the FAS ligand. I rather highlight here. FAS combines with the FAS ligand and it will form a trimerization, and trimerization will activate adapter protein, and activated adapter protein, what it will do? It will activate caspase 8. Where you see the activation of initiator caspase. Okay, what is the initiator caspase of your extrinsic pathway, which is caspase 8, and what is the initiator caspase of your intrinsic pathway, which is your caspase 9, and all three can activate, both of them, caspase 8 and 9 will activate executioner caspases. What are they? Caspases 3, 6, and 7. And then you have an endonuclease to nuclear damage and chromatin condensation. Endonuclease to nuclear damage and chromatin condensation will happen. So this is all about the apoptosis. Then you have a different types: necroptosis, necrosis plus apoptosis. But programs tell that will be there, but there is no caspase activation. Then you have a pyroptosis. It involves the activation of caspase 1 and 11. Very, 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 very important MCQ. What caspases will be activated on pyroptosis? Caspase 1 and caspase 11. Caspase 1 and caspase 11, and initiation caused by recognition of flagellin components of your Salmonella and Shigella. Okay. So what is a apoptotic pathway? Extrinsic, intrinsic. Intrinsic, stress, activation of backs back, and inhibition of BCL2 and MCL1. Mitochondrial permeability increases. Cytochrome C leaks out. Cytochrome C bind with apoptotic activating factor and it will initiate the caspase 9. Okay, then you have an extrinsic pathway where you see the FAS ligand and trimerization, activation of adapter protein, caspase 8 with the initiator caspase, and caspase 367 with the executioner caspase, and endonuclease activation, which in turn causes a nuclear damage. Necroptosis, necrosis, and apoptosis, while pyroptosis, activation of caspase 1 and 11. Now here is a table where you see the important stains. Here is the table where you see the important stain, and the few of them are cast in a FMGE. There is nothing else, just a mugging up part. So it is up to you. You have to remember or not. So if you want to score a 1 mark from the cell injury, you do not want to miss it, then you have to read that too. Okay, lipids are stained in oil red O stain, Sudan black, and you have this osmium tetroxide stain. And then you have the iron. Iron is stained in pearl Prussian blue stain, and calcium is stained in Vancosa and Alzarin red S, and glycogen, FAS and best carbon stain, copper, rhodamine and rubinic acid, melanin, Fontana mason, mucin, mucarine alkyne blue, and mast cell toluidine blue, amyloid Congo red, and hairy cell TRAP. So what are the things you have to remember here? Now coming to the point, what are the things you have to remember? You should not forget. Lipid, oil red O, and Sudan black are pretty important. You should not miss it. And then you have the copper, rhodamine, and you have the calcium, Vancosa, and Alzarin red S. And then you have this melanin, Fontana-Mason staining. You have the mast cell, which is a toluidine blue, which is you have a amyloid, Congo red. Amyloid is a kind of thing you should not forget at all. Okay, you have to remember that. Amyloid is Congo red. Then you have a hairy cell, which is a trap one. Then you have a hairy cell, which is a trap one. Then what are the changes will occur in the cellular aging? Increase in free radical, decreased expression of insulin like growth factor 1 gene, increased cross-linking of collagen, increased somatic mutation, and telomerase shortening will be seen here. Will be seen in the cellular aging. So far this is all about the cellular injury, people. So we have covered the cellular injury so far. And there are few image-based questions in the cellular injury. So first one is your metaplastic change, that is your Barrett esophagus, which was mentioned here. Now squamous to columnar conversion is happened here. And you have the apoptotic bodies. Langerhans cell, giant cells, Langerhans giant cell. And then you have a Sudan black stain, gel electrophoresis, where you see the step ladder pattern in the apoptosis, and then Pearl's reaction. Are the important images that you have to remember in the case of your, like a cell injury images as well as your theory portion. Okay. So remember, people, as I said, our primary focus is on the general and hematology. So lot of things will be discussed here because patho is considered to be the hidden giant. So if you are lucky enough, you may get a 6 to 7 question in this 2 division itself. Okay, remaining questions will come. If you are very lucky enough, 8 to 9 questions will come in this division itself. Okay, so make sure you know the concepts very good. Okay, now speaking about the inflammation, I don't want to mention all the things of inflammation that will be taking another 1 hour. So what I can do is, like, I will talk about the highlights of your inflammation. So first one, what is mean by inflammation? Inflammation is the response of cells to the particular injury. And what are the 4 cardinal signs of inflammation? That is your rubor, calor, dolor, and tumor. Which has been invented by Celsus. And you see the 5th cardinal sign of inflammation, which is your functional assay, which is invented by your Rudolf Virchow, who is considered to be the father of your pathology. Then, speaking about that, inflammation could be of acute and chronic. Since it is acute, it is of shorter duration. Well, since it is a chronic, it is of longer duration. And you see the local signs positive in the acute, and while the chronic one is mild symptomatic patients, you will see it in the chronic one. And then you have increased vascular permeability, and then you have this recovery and neutrophils. You may see it in the case of your acute inflammation, while mainly monocyte and lymphocyte mediated reactions you see in the chronic, and tissue destruction as a hallmark. Of your chronic inflammation. Okay, very important. So acute inflammation, you see first initially vasoconstriction, followed by vasodilation, followed by increased vascular permeability, and then you see the endothelial gap. So vascular endothelium and endothelial gap. So WBC will leak out and seal that. So what type of WBC what type of protein that will mediate the migration? So first one is Sialyl-Lewis X, which contains a selectin protein, where it is mediating the rolling of your WBC, and beta 2 integrin will produce a ICAM and a VCAM that mediates the adhesion, and then diabetes is mediated by PCAM or CD31, while chemotaxis, which is of O2 dependent or independent. O2 dependent is mediated by NADPH oxidase, while O2 independent is mediated by lysosomal oxidase. Very important MCQ. This table, the Sialyl-Lewis, selectin, and integrin table, if they want to test you with the inflammation, this is their choice of their question. So this table is kind of like a 5-star rated table. Okay, Sialyl-Lewis X will produce selectin, where you see which is mediating the rolling. Adhesion is mediating by integrin, we are on binding with the ICAM and the VCAM. Okay, and then you have a diapedesis, which is mediated by PECAM or CD31. Chemotaxis of WBC, it is a O2 dependent NADPH oxidase and O2 independent lysosomal oxidase. O2 independent, it is a lysosomal oxidase. So next is the inflammatory mediators. What are the inflammatory mediators we are having? One is your vasodilation. Vasodilation is mediated by prostaglandin, nitric oxide, and histamines. And vascular permeability increases by your histamine, serotonin, prostaglandin, and endothelial gap. WBC recruitment is done by chemokines and B4 and C5A. And opsonization is done by C3b IgG. Very important MCQ. Opsonization is done by C3b and IgG. And pain, bradykinin and prostaglandin E2. Pain, bradykinin and prostaglandin E2. And bronchoconstriction is mediated by PGF2 alpha. PGF2 alpha. Then you have a systemic complication, systemic mediators like a complement system, coagulation cascade, fibrinolytic system, and kinin system. Okay. Now, speaking about that, this is all about the inflammation. So, what are the cardinal signs? Ruber, Kaller, Doller, tumor, and functional assay. Rolling of WBC is mediated by silyl-Lewis exon selectin. Addition is mediated by beta-2 integrin on ICAM or VCAM. And diabetes is mediated by PCAM or CD31. While chemotaxis of WBC, O2 dependent NADPH oxidase, O2 independent lysosomal oxidase. Opsonization is done by C3b and IgG, while C5a, WBC recruitment, vascular permeability, prostaglandin, and serotonin and histamine. Vasodilation, prostaglandin, nitric oxide, and histamine. So, quite very important one. Quite a very important one. So, this is all about your inflammation, and this is all about your cell injury, people. So now shall I move on to the genetic disorder? Okay, speaking about the genetic disorder, we are having a type of inheritance and examples. So types of inheritance and example, the first one is your autosomal dominant. All picture-based questions are important and their examples are important. Last FMGE, you got 2 questions in this page itself. So this is also one of the pages where you read on prior moving on to the exam. So Marfan syndrome, the examples are Marfan syndrome, Huntington chorea, von Willebrand disease, otosclerosis, tuberous sclerosis, West disease, muscular dystrophy, HNPCC, BRCA1, BRCA2, autosomal dominant polycystic kidney disease, intermittent porphyria, Noonan syndrome, and osteogenesis imperfecta. So technically, if you don't remember any of the example, how do you remember? Any structural anomalies could result in, or any structural anomalies which have been passing from generation to generation, then it is autosomal dominant. If it is any enzyme defect, mostly you see the enzyme defect. If you see any enzyme defect, then that is related to your autosomal recessive. Okay, remember it like structural anomalies, you remember it like autosomal dominant, while enzyme defect mostly covers under the autosomal recessive. Apart from that, you have X-linked dominant and X-linked recessive, which are very less, you can be able to mug up on your own. So now speaking about the autosomal recessive consists of Wilson disease, alkaptonuria, phenylketonuria, sickle cell anemia, hemochromatosis, ataxia telangiectasia, infant polycystic kidney disease, Friedreichsen ataxia, Dubin-Johnson syndrome, xeroderma pigmentosa, Bloom syndrome, and cystic fibrosis, galactosemia, beta thalassemia, congenital adrenal hyperplasia, and alpha-1 antitrypsin deficiency. So mostly biochemical problems is related to autosomal recessive. For example, xeroderma pigmentosum and Dubin-Johnson syndrome, jaundice 1, enzyme defect, sickle cell anemia, again, missense mutation, and hemochromatosis, which is due to the accumulation of heme, and alkaptonuria, homogenthesis oxidase deficiency, galactosemia, galactose uridyl phosphate, uridyl 1-phosphate galactase deficiency. And apart from that, you have the congenital adrenal hyperplasia, and then you have what do we call it? We have this infant polycystic kidney disease, and Bloom syndrome, cystic fibrosis. Everything is related to the enzyme defect. So whenever you see the enzyme defect, it is mostly autosomal recessive. And whenever you see mostly the structural anomalies, then the gene defect, then it is mostly autosomal dominant. Then you have X-linked dominant one. So X-linked dominant is associated with the Alport syndrome, Fragile X syndrome, dermal hypoplasia, vitamin D resistant rickets, and incontinenta pigmenti. Then you have X-linked recessive, Hunter's, G6PD, and Becker's muscular dystrophy, Biscott-Ulrich syndrome, DMD, Duchenne muscular dystrophy, retinitis pigmentosa, Fabry's disease, hemophilia, and Lesch-Nyhan syndrome. Fabry's disease, hemophilia, and Lesch-Nyhan syndrome. Okay, then you have important diseases of your chromosomal anomaly and their features. So trisomy 21, Down syndrome, associated with the AML, Alzheimer's, and triple test positive, and nuchal thickness. Okay, you see the nuchal thickness, Alzheimer's, AML associations, and you see the triple test positive. Then you have a brittle chromosome, which is your Fragile X syndrome. So large testes, Sherman paradox, and triple repeat of your CCG nucleotide. And 45XO, Turner, primary amenorrhea, short stature, streaky ovaries, very, very important, short fourth metacarpal, and coaction of aorta. Coaction of aorta is seen in Turner's. Very, 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 very important MCQ. Okay, you should not miss it. I would rather highlight it in the different color. So coaction of aorta is seen in Turner syndrome. Primary amenorrhea along with the streaky ovaries, Turner syndrome. Okay, large testes, Sherman paradox. It is a Fragile X syndrome. Okay, Klinefelter, hypogonadism, gynecomastia, SLE, increased FSH and LH, and decreased inhibin and testosterone. Decreased inhibin and testosterone, while the genotype is your 47XXY. Okay, genotype is your 47XXY, hypogonadism, gynecomastia, SLE, decreased inhibin and testosterone. It is a Klinefelter. Trisomy 13, Patau syndrome, polydactyly. P stands for P, polydactyly, Patau, holoprosencephaly, and a cleft lip, Patau. And then you have the Edward, which is the trisomy 18. Trisomy 18, overlapping of flexed fingers and microxanthia. And trisomy 8, Warhang syndrome, where you see the miscarriage, short stature, mental retardation, and retarded psychomotor development. So 21, Downs, AML, Alzheimer, triple test, nuchal thickness. Okay, Fragile X, large testes, Sherman paradox, CCG, triplet repeat. Okay, Turner, 45XO, primary amenorrhea with the streak ovaries, and then coaction of aorta. Klinefelter, gynecomastia, hypogonadism, decreased inhibin and decreased testosterone with increased FSH and LH. Trisomy 13, Patau syndrome, polydactyly, cleft lip, and holoprosencephaly. And then trisomy 18, Edwards syndrome, where you see the microxanthia and overlapping of flexed fingers. And trisomy 11, trisomy 8, Warhang syndrome, where you see the miscarriage, mental retardation, and you may see the retarded psychomotor development. So this is the genetic diseases where you see all of them. Then next important table here is your chromosomal anomalies. So speaking about the chromosomal anomalies from 1 to 24 was mentioned here. Among that, the very, very important one is your Cry-to-Chat, which is chromosomal 5, RCC chromosomal 3, von Hippel-Lindau disease chromosomal 3, and cystic fibrosis chromosomal 7, and NF1 17, NF2 22. NF1 17 and NF2 22, phenylketonuria 12, Alzheimer's 14. Apart from that, Williams 7, Alzheimer's 14, achondroplasia 4, dominant polycystic kidney disease 4 and 16, and apart from that, you have Wilms tumor chromosomal number 11, and retinoblastoma gene is in 13, Patau is 13, and Wilson disease is 13, and Edward syndrome 18. Edward is 18, and tuberous sclerosis is 9, and osteopetrosis is 8. Osteopetrosis is 8, and hemochromatosis is 6. So main one is your achondroplasia 4, RCC and VHL, which is on 3, and Wilms tumor on 11, phenylketonuria on 12, cystic fibrosis on 7, NF1 17, NF2 22, and Edward syndrome was 18, and Friedreich's ataxia and tuberous sclerosis on chromosomal 9, and then chromosomal 16 was due to the tuberous sclerosis and autosomal dominant polycystic kidney disease. And then you have a mitochondrial inheritance. Affected females will transmit to all the offspring, but male won't transmit it. In the biochemistry we have studied, mitochondrial DNA contributes for about how many percent, people? Mitochondrial DNA contributes for about how many percentage? Mitochondrial DNA will contribute for about how many percentage? 1%. 1%, just 1% you have to remember. So you see the chromosomal 15, then chromosomal 15 deletion. If it is a paternal deletion, you see the Prader-Willi P for P. Maternal deletion, Angelman syndrome. Maternal deletion, Angelman syndrome. While Prader-Willi is due to the SNRP gene, while Angelman is due to the UBE3A gene. UBE3A gene. Both contains a mental retardation, but here Prader-Willi contains obesity, hypotonia, hypogonadism, and short stature, while here Angelman will have an inappropriate laughter. Very important MCQ. Okay, inappropriate laughter is seen in Angelman syndrome. Okay, so these are the one. This is a Fragile X syndrome, myotonic dystrophy, Friedreich ataxia, and Huntington disease. And Huntington disease, the gross pathology image, and you have the X-ray image of your Huntington together. Okay, then important HLA classes. Next is the immunogenetic and immunological. So we move on to the immunological. Important HLA classes. The main one is your B27, where I used to remember it with the mnemonic of pair. Psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, and Reiter's syndrome. PAIR, Reiter's syndrome or reactive arthritis. Any of these things you can call it. So spondyloarthropathies, ankylosing spondylosis, reactive arthritis, inflammatory bowel disease associated arthritis, psoriatic arthritis, and then Reiter's syndrome. All of them associated with the B27. Okay, B27. A3 is hemochromatosis, while B8, A3 is hemochromatosis, while B8 Addison's and myasthenia, and B47 congenital adrenal hyperplasia. Very important MCQ. CAH is associated with the what HLA? HLA B47. And B51, it is a Behçet's disease. CW6, it is a psoriasis vulgaris. DR4, it is a type 1 diabetes mellitus, pemphigus vulgaris and rheumatoid arthritis. DR3, which is associated with multiple diseases like Graves, myasthenia gravis, T1DM, Sjogren syndrome, dermatitis herpetiformis, chronic active hepatitis, Hashimoto thyroiditis, and Addison's. Most of them are associated with the DR3. And DQ8 and DQ2 celiac disease. DQ8 and DQ2 celiac disease, and DQ8 is associated with type 1 diabetes mellitus. DQ7 bullous pemphigoid, DQ5 pernicious anemia and Hashimoto's thyroiditis,
and DR2, SLE, multiple sclerosis, narcolepsy, and Goodpasture syndrome. SLE, multiple sclerosis, narcolepsy, and Goodpasture syndrome. So this is all about your important HLA classes and associated diseases. Among them, B27, B47, DR3, DR4, and DQ2 and 8, and apart from the DR5 are important. Okay, only 5 things you have to remember. B27, B47, DR3, DR5, DQ2, and DQ8 are the important ones you have to remember. Okay. So with this HLA class, we pass for 10 minutes of break. So take a 10 minutes of break and come back by 4:10. So we proceed with the other immunological factor. So we proceed with the T cell, B cell activation, and then their mechanism of action and all. Okay. So take a 10 minutes of break, take a good break, and then come back again so that we can able to proceed with the next section in your pathology. By 5 we finish like a hematology and a general path. By 5:30 we finish our systemic path too. Okay, so today we are going to finish the pathology. So take a good break and come back by 4:10.
Okay. So we are resuming the session 2 of your pathology. Now we are going to talk about the immunology. So speaking about the immunology, so we need to see about the T cell and the B cell activation. How does the T cell is being activated? Whenever the antigen is binding with the dendritic cell, the antigen may pass in and then it will bind with the MHC complex 2. MHC complex 2. The MHC complex 2 will then again transfer the antigen to the TCR T cell receptor of your CD4 positive cell. Okay, T cell receptor of your CD4 positive cells. And this dendritic cells, which contains a B7, which will also bind with the CD28, and then it produces the cytokine. This is how it will be getting activated. This is how it will be getting activated. So the dendritic cells contains the B7, which is CD80 or CD86, and which has the ligand here for the T cell receptor, which is CD28 positive. Whenever the antigen binds with them, the antigen will be transported to MHT2. MHT2 will go and bind with the T cell receptor of CD4 cell, and then it produces cytokines and destroys it. Okay. Similarly, for a B cell, we have a T helper cell, which contains the T cell receptor. So antigen on MHC complex 2 will go and bind with the T cell receptor and the T helper cell, and T helper cells will go and bind with the CD40. T helper cells has a CD40 ligand, which go and binds with the CD40 of your B cells and releases cytokine. The released cytokine will undergo the class switching of your B cell, and it will produce the inflammatory response. Okay, which one is determining the IG class switching of B cells? Which is a cytokine released by your T helper cell. And apart from the structure of your hemoglobin, each structure contains a 2 heavy chain and a 2 light chain. The 2 light chains are on the kappa and lambda, where the ratio is 2:1, and 2 heavy chain has a five subtypes. It will be classified as a IgG, A, M, E, and D. So you can able to remember it as a game, or you can able to remember it as a dimag, whatever you remember, or however you remember, you can remember accordingly. Okay, you can remember accordingly. Okay, now speaking about the immunoglobulin classes, so IgG, which is maximum in concentration and crosses placenta, very important MCQ, crosses placenta. And IgA, it will prevent the bacteria and viral attachment in mucosal membrane. It will prevent the bacteria and viral attachment in mucosal membrane. IgM, maximum molecular weight and act on B cells. IgD, unclear function, so it is found on the B cells. IgE, lowest concentration and produces type 1 hypersensitive reaction. So what are the things here you have to remember is, one is your most common or most abundant one is G, which can cross placenta, and maximum molecular weight is M, and IgE produces type 1 hypersensitive reaction. Type 1 hypersensitive reaction. So these are the things. So the RIMA one you have to remember, I highlighted in the red color. So crosses placenta is IgG, and type 1 hypersensitive reaction, it is IgE, maximum concentration and act on B cells, it is IgM, it is IgM. You have to remember this. And marker for NK cells are CD16 and CD56. Very important MCQ. What are the CD markers for NK cells? Okay, which is your CD16 and CD56, which is your CD16 and CD56. You have to remember. Then you have the hypersensitivity reaction. Speaking about the hypersensitivity reaction, we are having 4 types of hypersensitivity reaction, people. We are having how many types? 4 types. So what are they? First one is a type 1 hypersensitive reaction, which is mediated by, as we studied in IgE. Yeah, IgE mediates the type 1, where the mechanism is allergen and IgE will bind to FCR mast cells, and the allergen bind to allergen IgE. Then you see the cross-linking, and then you see the mast cell degranulation. You see the mast cell degranulation. And type 2, it is the cytotoxic one, where IgG or IgM is mediating it. Both binds to the cellular antigen by activating a complement system, and causes a cellular lysis. Okay, then you have an immune complex, same IgG, IgM, but here antigen antibody complex will deposit in the tissue and activation of complement system, and activated complement will attract neutrophils and release of lysosomal enzyme Then you have a type 4, which is a delayed one. So speaking about the delayed one, it is both soluble and cell bound, where you see the CD4 activation and release of cytokines and inflammation and macrophage activation. So the important examples where I used to, for a type 1, I used to remember it like a 5 A's with a CIDS. Okay, 5 A's with the CIDS. 5 A's with CIDS. Okay, so 5 A's are the anaphylaxis, asthma, atopy, angioedema, and atopic dermatitis. Okay, anaphylaxis, asthma, atopy, angioedema, and atopic dermatitis, while CIDS are Cassoni test, insect bite, drugs, and seasonal hay fever. Okay, 5 A's with the CIDs are the classical example of your type 1, which is mediated by IgE. Type 1, which is mediated by IgE. Okay, then type 2, lot are there in the type 2 and the type 3. So you have to remember myasthenia gravis, transfusion reaction, Goodpasture syndrome, Graves' disease, graft hyperacute rejection. Remember, ITP, AIHA, autoimmune hemolytic anemia, RH incompatibility, rheumatic fever, and pemphigus. Then you have a type 3, which is a serum sickness, Schick test, SLE, HSP, hypersensitivity pneumonitis, Arthur's reaction, acute glomerulonephritis, rheumatoid arthritis, and PAN, and type 2 lepra reaction. Okay, polyarthritis nodosa and type 2 lepra reactions. Then you have a type 4 TB, type 1 lepra reaction, sarcoidosis, IBD, multiple sclerosis, psoriasis, type 1 diabetes, contact dermatitis, and tuberculosis lepra test, and a freeze test and a patch test. There is nothing else, people, you have to remember. You have to remember all the things you have to remember, and you have to mug it up also, because this is very, very important slide. So this is one of the slide where you read 1 hour prior to the examination. So when you are sitting in the car, you take a few pages, you turn over those pages, and to make sure like you answer it right. One among these pages is this, because definitely one question may come on this page. I cannot say definitely, but 90% you may expect to see a question here. Okay. Types of hypersensitivity reaction, either a mechanism or what type it is anaphylactic or cytotoxic or immune complex mediated or delayed one, or maybe what type of immune reactant is playing a role here, IgG or IgM or IgE or T cell or B cell, or like what type of mechanism is it doing, or like they may give you some disease and they may ask like what type of hypersensitivity reaction it is. But all the things will be expected, and you may expect 90%, 80 to 90% one question from this. You should not miss it. Okay, so with this we have completed our general pathology section completely. So now we are moving on to our hematology section. Speaking about the hematology, the first area we are going to talk about is your anemia. What is anemia? Reduction in the circulating RBC mass is so-called as anemia. What are the indices we are using it for the calculation of anemia? So the first indices we are using is your MCV. So average volume of RBC in the cell is so-called as MCV. What is the normal MCV value? 82 to 96. Increases in megaloblastic and decreases in iron deficiency. And then you have a MCH. Average hemoglobin content per RBC, normal is 27 to 33, and increases in megalo and decreases in microcytic hypochromic. Could be of any cause. Okay, then you have a MCHC, average hemoglobin concentration in given volume of RBC. Normal value is 33 to 37 and normal in megaloblastic anemia, while increases in hereditary spherocytosis and microcytic hypochromic anemia. Then RDW, normal RDW is 11.5 to 14.5, increases in megaloblastic, iron deficiency, immune hemolytic anemia. Okay, then you have a hematocrit where the normal value is 45% for men and 42% for women. 45% for men and 42% for your women. And apart from that, you have anemia, hemoglobin less than 13.5 gram per deciliter in male and less than 12.5 gram per deciliter in female. So how do you classify the anemia, people? How do you classify the anemia? We could able to classify the anemia based on the MCV value, which would be likely to be like a microcytic, normocytic, and macrocytic anemia. Okay, microcytic, normocytic, and macrocytic anemia. So coming from the macrocytic, the causes of your macrocytic anemia could be megaloblastic, alcoholism, any liver disease, or any hypothyroidism, or any myelodysplastic syndrome that can cause us a macrocytic anemia, while normocytic should be aplastic, myeloplastic, and hypothyroidism, chronic renal failure, and anemia of chronic disease. Anemia of chronic disease. While microcytic anemia, due to the loss of production of hemoglobin, so hemoglobin consists of heme and globin. Defect heme consists of iron and protoporphyrin. So iron deficiency could result in iron deficiency is due to either a iron deficiency anemia or due to the chronic disease. Okay, dietary deficiency of iron or maybe due to the chronic disease. Then protoporphyrin deficiency could result in sideroblastic anemia, while globulin chain could result in thalassemia. Globulin chain could result in thalassemia. Okay, what is the location of absorption of iron? Proximal duodenum. Absorptive form is ferrous form. Absorptive form is ferrous form. So lack of iron. So the iron will be taken from the storage. So there will be a decrease in ferritin. When there is a decrease in ferritin, then there is a decrease in serum iron and serum hepcidin. And when there is a decrease in hepcidin, you see the increase in transferrin and increase in TIBC. Increase in transferrin and increase in TIBC. And remember one thing, transferrin concentration increases, but percentile saturation of your transferrin will decrease. What happened? Percentile saturation of your transferrin will decrease. What are the causes? It could be a decrease in the dietary iron intake. It could be a decrease in dietary iron intake, malabsorption, increased demand, and chronic blood loss. Malabsorption, increased demand, and chronic blood loss. And lab findings are decreased serum iron, ferritin, increase in TIBC, and normal to increase in transferrin with the decrease in transferrin saturation. Okay, complication, Plummer-Vinson syndrome, where you see iron deficiency anemia, esophageal web, and atopic glossitis, where you see the beefy red tongue in iron deficiency anemia. Very, 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 very important MCQ. Okay, very, 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 very important MCQ. Okay, then you have anemia of chronic disease, ACD. So what is the triad of Plummer-Vinson syndrome? Once again, people, it's an iron deficiency anemia, esophageal web, and followed by atopic glossitis. Then anemia of chronic disease, inflammation, stimulation of hepcidin, and inhibition of erythroid precursor, and inhibition of erythropoietin, and inhibition of ferroportin. So that in turn causes a movement of iron from blood to storage. Okay, blood to storage. So you may have a decrease in serum iron, but increase in ferritin and decrease in TIBC and decrease in transferrin saturation. Decrease in transferrin saturation. All of these things will be seen in this situation. Okay, clear about that? So clear about the anemia of chronic disease mechanism. Inflammation, chronic inflammation could stimulate hepcidin, which in turn decreases your erythroid precursor, erythropoietin, and ferroportin. That in turn causes a movement of your iron from the blood to the storage to prevent the iron consumption, and that in turn causes an increase in ferritin but decrease in serum iron. Then protoporphyrin deficiency could result in sideroblastic anemia. So lack of protoporphyrin, lack of hemoglobin. So congenital defect, delta ALA synthase 1, while acquired is due to the drug defects such as isoniazid, chloramphenicol, alcoholism, and lead poisoning. Smear shows ringed sideroblast people. Smear shows a ringed sideroblast. Here it is, the ringed sideroblast. Smear shows a ringed sideroblast here. Okay, and lab finding shows a decrease in TABC. Very important MCQ. TABC will be decreased in sideroblastic anemia. And then thalassemia. Thalassemia, the test for thalassemia is Nesterov test. It could be of alpha and beta. Alpha, gene deletion in chromosome 16. It contains a 4 gene. So if it is a 1 gene defect, you see the silent mutation. 2 gene defect, mildly symptomatic. 2 gene defect could be cis or trans. Cis is seen in Asians, while trans is seen in Africans. And a 3 gene defect could result in the formation of HPH. And a 4 gene defect could result in the formation of HP drops and HP BART, and HP BART could result in the hydrops fetalis condition. Hydrops fetalis is associated with the alpha thalassemia with the 4 gene defect. Ringed sideroblasts are seen in sideroblastic anemia. So acquired sideroblastic anemia is due to the isoniazid drug, or maybe alcoholism, or maybe delta lead poisoning, which inhibits delta ALA dehydratase and ferrochelatase enzyme. Okay, then you have a beta thalassemia, where the point mutation is seen in the chromosome 11. Point mutation is seen in the chromosome 11. Okay, and if the chromosome 11, 1 gene defect, beta thalassemia minor, 2 gene defect, beta thalassemia major. Beta thalassemia major. While that smear shows the target cells and X-ray shows a crew-cut appearance. X-ray shows a crew-cut appearance on the skull and chipmunk faces. Crew-cut appearance, chipmunk faces, target cell, beta thalassemia. Okay, chromosome 11. Alpha thalassemia, 4 gene defect. 1 gene defect, silent. 2 gene defect, then there is a cis or trans. Cis is seen in Asian and trans is seen in African. And 3 gene, formation of HPH, and you see the severe anemia. 4 is HP BART, where you see the hydrops fetalis. Okay, where you see the hydrops fetalis. So with this, we have completed microcytic anemia. Next, macrocytic anemia. On the macrocytic anemia, you see the megaloblastic, lack of folate or vitamin B12, no DNA precursor synthesis. So impaired division and enlargement of your RBC precursors. So there will be a no RBCs to be produced. So you may see the hypersegmented neutrophils here. Very important. Neutrophils will show 5 to 6 segments. So hypersegmented neutrophils is a characteristic feature of your your megaloblastic anemia. And megaloblastic anemia will have a triad. Megaloblastic anemia will have a triad: microovalocytosis, hypersegmented neutrophils, and Howell-Jolly bodies. Howell-Jolly bodies. So smear shows hypersegmented neutrophils and basophilic stripling, Cabot's ring, and Howell-Jolly body. This is a Howell-Jolly body. This is the Howell-Jolly body, where you see the Cabot ring, basophilic stripling, and Howell-Jolly bodies in the smear of your you smear of your megaloblastic anemia. Then you also see the teardrop cells, and you also see the teardrop cells. So mostly folate deficiency or vitamin B12 deficiency. So folate deficiency, it was associated with the NTDs, macrocytic anemia, with the normal methyl melanoic acid levels. Remember, folate, you may see normal methyl melanoic acid level, while vitamin B12 depth, where you see methyl melanoic acidemia, which is increased methyl melanoic acid in the level. And you see subacute combined degeneration of spinal cord. The test for the vitamin B12 deficiency is your Schilling test. And you see that there is a the factor which is required for the absorption of vitamin B12 in the terminal ileum is your intrinsic factor. That's why vitamin B12 is also called as extrinsic factor of your Castle. So you may result in pernicious anemia if it is a autoimmune. Pernicious anemia if it is a autoimmune, where you see increased homocysteine and increased methyl melanoic acid.
This was asked in FMGE once. Increased methyl melanoic acid level indicates what? Okay, methyl melanoic acid with increased homocysteine indicates there is a deficiency of vitamin B12. There is a deficiency of vitamin B12. Then you have this normocytic anemia. Normocytic anemia is due to two factors, either due to the excessive destruction or due to the underproduction. Either due to the excessive destruction or due to the underproduction. So excessive destruction means hemolysis. So it could be of either intravascular hemolysis or extravascular hemolysis. So intravascular hemolysis, hemoglobinemia, hemoglobinuria, and you may see as a hemosideриnuria. Increased urine hemosiderin levels will be seen in the case of intravascular hemolysis. Intravascular hemolysis, while bilirubin synthesis or bilirubin will be excreted in extravascular one. Bilirubin, splenomegaly, and jaundice are the characteristic feature of your extravascular hemolysis, while hemosideриnuria with the decreased serum haptoglobin level is seen in intravascular hemolysis. Then you have a hereditary spherocytosis, inherited defect of your membrane protein, which is anchoring your RBC. So there is a membrane protein such as ankyrin, spectrin, band 3, protein 4.2. All of them will not work. So when this is not working, membrane integrity will break. Membrane integrity will break. Then you may see the blood which has been removed by the macrophages. You see the biconcave shape of your RBC converted into spherocyte. Okay, which is converted into spherical or spherocyte. So this is so called as a spherocyte. So you should not know. You should know that where you see the lack of the central pallor, where you see the lack of the central pallor, which is associated with the spherocytes, where the lab investigation shows increase in RDW and increase in MCHC. And test for the hemolytic anemia is your osmotic fragility test. Osmotic fragility test for like hereditary spherocytosis. Then you have a sickle cell anemia, missense mutation, where glutamic acid is replaced by valine in its 6th position. Glutamic acid is replaced by valine in its 6th position, where two abnormal beta genes has been produced. Formation of HPS, which is a sickling will occur. That in turn causes a sickling of your RBCs. So you may see the anemia. And you may also see the gamma antibodies in the spleen. Okay. Then you have a aplastic anemia. Speaking about the aplastic anemia, hematopoiesis cell will not work. All blast cells will not work. Pancytopenia will be there. On the biopsy shows empty and fat marrow. Very, 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 very important MCQ. Biopsy showed empty and fat bone marrow. Empty and fat bone marrow. You may see it in the biopsy on the aplastic anemia. When you see the pure red cell aplasia, where you see the congenital or acquired, congenital is due to the diamond blackbone anemia, and you may also see the acquired one is due to the thymoma or with the large granular lymphocytic leukemia. Okay, large granular lymphocytic leukemia, or it is associated with the drugs such as NSAIDs, So this is all about the anemia. You're having the different variety of hemoglobin and their side chain. Pretty important 7-star rated topic, mug-up topic. You should not miss it. So hemoglobin F, alpha to gamma 2, A, alpha to beta 2, A2, alpha to S2, and HBH, alpha 1, beta 3, HB bar, gamma 4, and you have this Gover 1, theta 2, and epsilon 2, Gover 2, alpha 2, epsilon 2, and Portland 1, zeta 2, and gamma 2, and Portland 2, zeta 2, and beta 2 chain. Very, 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 very important MCQ. Abnormal hemoglobin side chain and their names. Abnormal hemoglobins and their side chain and their names. Very, 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 very important. Then you have a leukemia and lymphoma. Speaking about the leukemia, ALL, neoplastic proliferation of your blood cells with over 20%, where failure in the differentiation that could lead to pancytopenia. Okay, and acute leukemia could be ALL and AML depending upon the origin. So ALL is TDT positive, and it is a most common neoplasm in children. And it is a most common neoplasm in children associated with the Down syndrome and Fanconi's anemia, Bloom, Klinefelter, and ataxia telangiectasia. While AML is positive myeloperoxidase, where it crystallizes and present in the form of your IR rods. So what are the types of ALL? So we are having a pre-BALL, which is the most common type, where you may see good prognosis is associated with the T 12:21. Good prognosis is associated with the T 12:21, while poor prognosis is associated with the T 9:22. So pre-TALL again, thymic mass, teenagers, TDT positive, CD2 to CD8. Pre-TALL 4 Ts. 4 Ts. What are they? TDT positive, thymic mass, teenagers, and CD2 to CD8. While AML, positive myeloperoxidase, where you see the crystalline and causes a IR rod. IR rod is seen in what stage? Another important MCQ, M3 stage people. IR rods are seen in AML M3 stage, where the investigation of choices flow cytometry. And AML type, the important one is your M2, which is T8:21, and M3, which is T15:17, where you see the maximum IR rods. M5, infiltration in gum, and M7, megakaryocytic maturation. So you may see the bone marrow fibrosis and pancytopenia. So this is all about the AML and the ALL. Next, we are talking about the CLL, also known as small lymphocytic leukemia, and it releases CD5, CD20, 23, and 19. CD5, CD20, 23, and 19, where the smear shows smudge cells, basket cells, or parachute cells. Smudge cells, basket cells, or parachute cells. Okay, and investigation of choices, flow cytometry. Okay, then you have a hairy cell leukemia, where trap positive and hairy cytoplasmic projections you may see, fried eggshell appearance and honeycomb appearance you may see on bone marrow biopsy. Fried eggshell appearance and honeycomb appearance is shown on hairy cell leukemia bone marrow biopsy. And what is the most specific marker for hairy cell leukemia? It is a annexin A1. Next is a mucosal fungoides, where you see the T-cell leukemia and lymphoma, and you see this, it goes and attacks the skin and causes a epidermotrophism, and it will accumulate in the epiphysis and causes a putreous microabscess. Mucosal fungoides, you see the putreous microabscess. We saw that mucosal fungoides image yesterday on dermatology. Smear shows Sézary cells. And then you have a CML, where you see the BCR-ABL resistance, and you see the T9:22 mutation. T9:22 mutation with the BCR-ABL resistance, where you see the tyrosine kinase will not work. Okay, so resistance can able to stimulate the tyrosine kinase. Then you have the lymphoma. Speaking about the lymphoma, first one is your marginal cell lymphoma. Marginal cell lymphoma is due to the neoplastic proliferation of your B cells, which expand to the marginal zone. Well, the characteristic features are your Hashimoto thyroiditis, Sjogren's, and H. pylori. Translocation 11:18, 14:18, and 1:4. While Burkitt lymphoma, this image has been very important. Mandibular infection, T8:14. And most common cause of tumor lysis syndrome. Smear shows starry sky appearance. Smear shows starry sky appearance. So speaking about the bullets, look at the image and look at the starry sky appearance, and it is the most common cause of your tumor lysis syndrome. Apart from that, your non-Hodgkin's lymphoma could be of a small cell, intermediate, and large cell. On that small cell, we talk about the follicular lymphoma. So the follicular lymphoma, where you see the defect in P14:18, which in turn leads to increase in BCL2 expression, inhibition of apoptosis. So lymph node biopsy, you may see buttock cell, and the bone marrow biopsy, you may see the paratrabecular lymphoid aggregation. And treatment, it is a rituximab. Then you have a mantle cell lymphoma, people. Speaking of a mantle cell lymphoma, speaking about the mantle cell lymphoma, where the translocation occurs from chromosome 14 to 11. 14 contains the IGH, which has been moved to 11 cyclin D1. So that in turn causes increase in cyclin D1 expression. Whenever more cyclin D1 is there, then there is an increase in movement of cells from G1 to S phase, and then you causes a proliferation. Again tumor, which is a lymphoma. But here the cell type is a mantle cell lymphoma, where you see painless lymphadenopathy, and expresses CD5 and 23. So mantle cell lymphoma, chromosome number 14:11 translocation causes increase in cyclin D1 expression, movement of cells from G1 to S, proliferation. Expresses CD5 and CD23. Okay. Then Hodgkin's lymphoma. Speaking about the Hodgkin's lymphoma, the types are nodular sclerosis, mixed cellular, lymphocyte dominant, and lymphocyte depleted. Among them, the nodular sclerosis is the most common form, people. So what are the four types? Nodular sclerosis, mixed cellularity, lymphocyte dominant, and lymphocyte depletion. Among that, nodular sclerosis is the most common form, while mixed cellularity is the most common one in developing countries. Then you have a multiple myeloma, where you see the IL-6 release, where you see the plasma cell growth, where you see the activation of rank L, vitamin D, rank L, osteoclast, movement of your calcium from the bone. So you see the punched out lesion and hypercalcemia. So speaking about that, what are the things you have to remember in the multiple myeloma, people? Very short and sweet. We will finish the multiple myeloma. What are the things you have to remember in the multiple myeloma? One, punched out lesion. Okay, one, punched out lesion. Another one, Benz-John protein in the urine. And what is the CD marker, people? CD marker is CD56 and 138. What is the CD marker? 56 and 138. Then, due to the increase in the release of IgM, you see the M spike in your SPEP. Okay, you see the M spike in the SPEP and Role formation. So that in turn accumulates in the cell. You see the Dutcher bodies, you see the Russell bodies, you see the Mott cells, and you see the flame cells. Multiple myeloma is one of the 3-star to 5-star rated topic, man. Okay, so punched out lesion, Benz-John protein, CD56 and 138, M spike and SPEP, flame cell, Mott cell, Dutcher bodies, and Russell bodies. Okay, Dutcher bodies and Russell bodies. All of them are present in multiple myeloma. Then you have the Waldenström macroglobulinemia, where you see the monoclonal IgM, you see the hyperviscosity syndrome. Where bone marrow biopsy again shows Dutcher bodies and Russell bodies. Okay, then we have a Langerhans cells histiocytosis. Speaking about the Langerhans cells histiocytosis, where you see the Baerbeck granules or tennis racket granules and Langerin protein, which is a marker of CD207. And apart from that, it may express HLA-DR, S100, and CD1A. HLA-DR S100 and CD1A and CD207 with the Baerbock granules. Okay, then you have a types and a Hand-Schiller. You have this letter CV disease, and you have this eosinophilic granuloma, and then you have the Hand-Schiller-Christian disease, and you have this Hand-Schiller-Christian disease. Among that, letter CV is very, very important, where you see the skin and bone defect, you see the seborrheic dermatitis. You see the seborrheic dermatitis. So speaking about the Langerhans histiocytes, what are the things you have to remember? Baerbock or tennis racket granules, Langerin protein, which is CD207, expression of HLA-DR S100 CD1A, HLA-DR S100 and CD1A, and complication letter CV disease, where you see the seborrheic dermatitis, Then hemostasis and related disorder, primary hemostasis, which is due to the damaged vessel, and where van Willebrand factor will bind with the subendothelial collagen. You see the platelet regranulation and platelet aggregation. So this is what primary hemostasis is maintaining. First area is your immune thrombocytopenic purpura. The first disease we are going to see is your immune thrombocytopenic purpura. So what happens here is there is an antibody which is directed against the platelet antigen. The antibody which is directed against the platelet antigen, that is your GP26 and 3A. Okay, GP26 and 3A. So since the GP26 and 3A is blocked, then will there be any platelet aggregation, people? Will there be any platelet aggregation? No platelet aggregation. Yes or no? When there is no platelet aggregation, automatically what will happen? The platelet plug formation cannot be happening. Patient is having a normal PT and APTT, but there is an increase in megakaryocytes along with decrease in platelet count, because antibodies were directed against the platelet antigen, that is your 2B and 3A. Yes or no? 2B and 3A, which in turn destroys your platelets. So no platelets here. Okay, and treatment of choices IVIG and splenectomy. Then you have a microangiopathic hemolytic anemia, which is seen in TTP and HUS. So TTP, where you see the ADAM-TS13 gene defect, hemolytic uremic syndrome, where you see the E. coli O157H7 gene defect, serotype defect, E. coli O157H7 hemolytic uremic syndrome, while TTP ADAM-TS13 gene defect. And there is a triad for HUS, which is your microangiopathic hemolytic anemia, along with thrombocytopenia and renal dysfunction. Where you see the increase in BT. Then you have a Bernard-Solier syndrome, GP1B defect, improper addition, thrombocytopenia with enlarged platelet. Bernard-Solier syndrome is seen in large platelet defect. Okay, and Glimsman thrombasthenia, 2B3A defect, impaired platelet aggregation, where you see the positive restocilin addition test. Then you have a secondary hemostasis disorder, where you see the hemophilia A and B and C. A is factor 8 X-linked recessive, B is Christmas factor defect, and C is factor 11 defect, which is autosomal recessive defect. So with this we are completing your hematology section. So next possible section is your systemic pathology. So speaking about the systemic pathology, the first one is your cardiovascular system, people. So the first one is your atherosclerosis, where you see the thickening and luminal narrowing. And atherosclerosis could be of arteriosclerosis and Monckeberg's medial calcific sclerosis. So arteriosclerosis could be of hyaline and hyperplastic. Hyaline is benign, and it hyaline is seen in benign hypertension and diabetes mellitus, while hyperplastic is seen in onion skin-like appearance, type 1, malignant hypertension, and fibrinoid necrosis.
So we already studied arteriosclerosis. You may see, or any vascular disorders, you may see the fibrinoid necrosis. We studied that in the cell injury. Yes or no? We studied that in the cell injury. Then you have a atherosclerosis, which is a major elastic arteries. You may see the atherosclerosis, where you see the ischemia and infarction. And the Monckeberg's medial dystrophic calcification. Very, 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 very important. Monckeberg's medial calcific sclerosis is dystrophic calcification, where you see the median muscular arterial occlusion and you see the calcific deposition also. And you may also see the calcific deposition. Then vasculitis, giant cell arteritis, most common artery involved in giant cell arteritis is very, 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 very classic MCQ. Superficial temporal artery or superior temporal artery. And you may see the segmental granulomatosis. You may see the segmental granulomatosis in the giant cell arteritis. Okay. Upper limb pulse headache, superior temporal artery, segmental granulomatosis are the three things you have to remember in terms of giant cell arteritis. Takayasu, pulseless, arch of aorta involvement. Arch of aorta involvement. Polyarteritis nodosa, fibrinoid necrosis, HbA1c positive. HbsAg positive. Not HbA1c, sorry, HbsAg positive. Then microscopic polyangiitis, Pianka positive. Polyangiitis, Pianka positive. Pulmonary artery, glomerular nephritis, and no HbsAg positive, and drug-associated vasculitis. So 3 P's for polyangiitis, microscopic polyangiitis, 3 P's, Pianka, pulmonary, and kidney. Okay, polyangiitis, Pianka, pulmonary artery. Okay, apart from that, myocardial infarction. Speaking about the myocardial infarction, so what are the things you may see? In the light microscope, only 4 hours, you may see the variation in the myocardial fibers. After that, you cannot able to find it. Then you find the gross examination. For gross, more than 12 hours, you may do the TTC test. Granulation will be seen in 7 to 10 days and scar will be seen for 2 months. Okay. And whatever the markers, we discussed that in the biochemistry, so we don't want to mention it here. And then we have a rheumatic heart disease, where you see the fish mouth or buttonhole ulcer, McCallum patch, AV valve vegetation, and beta hemolytic group A streptococcal infection, and Ashcroft bodies. Ashcroft bodies, McCallum's patch, AV vegetations, fish mouth or buttonhole ulcer. Fish mouth or buttonhole ulcers, you may see it in the RHT. You may see it in the RHT. Okay. Apart from that, cardiomyopathy, hypertrophic, dilated, and restrictive. Hypertrophic is asymmetrical IV septum is the structure involved, lack of compliance, diastolic dysfunction. While dilated, it is a systolic dysfunction. While restrictive, there is a lack of compliance, and again, it is a diastolic dysfunction. Okay, again, it is a diastolic dysfunction. Now, speaking about the cardiac tumor, most common cardiac benign tumor is left atrial myxoma. Most common cardiac tumor is your left atrial myxoma, which is associated with the Carney syndrome. And the commonest tumor in children is RMS. Then you have a respiratory, where you see the obstructive and the restrictive type of diseases. So we talked about the obstructive and the restrictive pattern back in the physiology itself. So we don't want to talk much about that. But here we talk about certain things about the respiratory diseases. First one is emphysema, pink puffer, abnormal enlargement of alveoli, divided into centriassignard, panassignard, parassignard, irregular. Irregular is associated with pneumothorax. Parassignard is associated with upper lobe scarring. Panassignard is associated with alpha-1 antitrypsin, while centriassignard is associated with the smoker. Then you have a chronic bronchitis, blue bloater, increase in Reitz index. Bronchial asthma, 3 C's, Priola body, Crushman spirals, and Charcot-Leyden crystal. You have to remember the 3 C's. Priola bodies, Crushman spiral, Charcot-Leyden crystals. Bronchiectasis, you may see abdominal bronchi, infection, or maybe situs inversus, or maybe due to secondary amyloidosis, Among that secondary amyloidosis, A beta type is associated with the Alzheimer's, A cal is associated with the medullary carcinoma of thyroid, and A beta 2M is associated with the hemodialysis, and AL type, which is primary, associated with multiple myeloma. Now, speaking about amyloidosis, what are the things you have to know in terms of amyloidosis? Congo red strain, apple green bifringence, AL multiple myeloma, A beta Alzheimer's, A beta 2M associated with hemodialysis, and ACAL medullary carcinoma of thyroid. Okay, these are the things you have to remember in case of amyloidosis, 3-star to 5-star rated. Let me repeat again. Congo red strain, apple green bifringence, multiple myeloma AL, A beta 2M hemodialysis, A beta is Alzheimer's, ACAL is medullary carcinoma of thyroid. ACAL is medullary carcinoma of thyroid. Then you have a pneumoconiosis, coal workers pneumonia, upper lobe of lung, asbestosis, which is associated with the asbestos fibers, where you see the ferruginous bodies and asteroid bodies, and silicosis, eggshell calcification, cotton is bazzinosis, jute is bagosis, sugarcane is stanosis. Okay, sugarcane is stanosis. Coal workers, upper lobe, asbestosis, ferruginous bodies and asteroid bodies, and associated with the mesothelioma and cancer colon, and cotton, bazzinosis, jute bagosis, sugarcane stanosis, silicosis, you may see it in the eggshell calcification and upper lobe. And upper lobe. You have to remember this, people. Very, 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 very important. Okay, then pneumonia. Speaking about the pneumonia, common organism causing a community-acquired pneumonia is strep pneumo. Nosocomial is Pseudomonas. Cystic fibrosis is Pseudomonas and Staph aureus. Lung abscess is Staph aureus and Klebsiella. And most common organism causing a nematocele Staph aureus. Okay, nematocele Staph aureus. Any old man, chronic alcoholic, DM, then Klebsiella. Any old man, chronic alcoholic, DM, it is Klebsiella. Or any nosocomial pneumonia, which is hospital acquired one, think about most predominantly Pseudomonas. Think about the Pseudomonas. Okay. Then atypical pneumonia, which is the Mycobacterium pneumonia or Legionella pneumophilia. You may see it in this patient. Then you have a tumors of lungs, squamous cell carcinoma, where you see the, like a P53 and parathyroid, central and smokers. Adeno, non-smoker, KRAS. Adeno, non-smoker, KRAS. Bronchoalveolar carcinoma, you see the Clara cells. Then you have a small cell or wart cell, which is the most common one. Salt and pepper appearance will be seen. And you may also see Azzopardi effect. Okay, you may also see the Azzopardi effect apart from the large cell one. Okay, so with this we have done with the respiratory system. So what are the things? We have talked about the respiratory system. Centroacine are associated with the smoker. Panacine are associated with the alpha-1 antitrypsin. And chronic bronchitis is blue bloaters with increased rates index. Bronchial asthma, 3 Cs, Priola bodies, Freshman cirrals, and Charcot-Leyden crystals. Then you have amyloidosis, primary, AL, multiple myeloma, A beta, Alzheimer's, A beta 2M, hemodialysis, ACAL, medullary carcinoma of thyroid. And apart from that, you have to remember is Congo red strain with apple green bifringence. Then you have a pneumoconiosis, coal workers pneumonia is upper lobe, asbestosis, ferruginous bodies and asteroid bodies, silicosis, eggshell calcification, cotton, bazzinosis, jute, bagosis, sugarcane stanosis. Then we talked about that. What are they? Once again, people. So upper lobe of lungs, a coal worker and silicosis. Asbestosis, you may see the ferruginous and the asteroid, cotton, bazzinosis, jute, bagosis, sugarcane stanosis. Then you have a pneumonia. Most common community acquired strep pneumo. Cystic fibrosis is Pseudomonas. Nosocomial is Pseudomonas. Lung abscess Staph aureus. And chronic alcoholic, DM, old age, Klebsiella. Okay. Tumors of lung, P53, parathyroid, squamous cell, smokers. Squamous for smoker. Adeno, non-smoker. Bronchoalveolar carcinoma, you see the Clara cells. And the small cells are wart cell carcinoma, you see the
salt and pepper appearance, KRAS mutation, and azopardy effect. With this, we have completed the respiratory system. Now we move on to the GIT. We move on to the important things in the GIT. So first one is your Plummer-Vinson syndrome, which is a complication of your microsomic hypochromic anemia, which is your iron deficiency anemia complication. We studied that in the IDA itself. Yes or no? One of the complications is Plummer-Vinson syndrome, where you see the triad. What triad of your Plummer-Vinson syndrome triad? Glossitis, esophageal web, and microcytic hypochromic anemia. Esophageal web and microcytic hypochromic anemia. And microcytic hypochromic anemia. All three is a triad of your Plummer-Vinson syndrome. Then fistula, most common type is type C. H type is type E. You have to remember. Very, 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 very important. Achalasia cardia, relaxed LES with the bird beak appearance or Hurst phenomena. Gastric carcinoma, most common is adenocarcinoma, and Virchow's node you may see. And gastrointestinal stromal tumor, where you see the interstitial cells of Kajal, where you see the CD marker as CD117 positive. And then Menetrier's syndrome, where you see it is associated with the adenocarcinoma, which is associated with the adenocarcinoma. In the large intestine, you talk about two diseases. One is your Hirschsprung disease, where you see the congenital aganglionic megacolon and rectosigmoidal region. And pseudomembranous peritonitis, secondary to mucinous serous adenocarcinoma. And you may also see it as an adenocarcinoma of appendix. Adenocarcinoma of appendix, you may see as a complication as a pseudomyxoma peritonitis. Pseudomyxoma peritonitis. And in the hepatobiliary system, what are the important appearances you have to know? Ground glass hepatitis, HBV. Lumping, microvesicular, increased PTR-BT, HCV. Central lobular necrosis, CVC liver. Midzonal necrosis, eclampsia. Mallory-Hyland, alcoholic hepatitis, Wilson disease, hemochromatosis, hepatocellular carcinoma. Councilman bodies, yellow fever. Bridging necrosis, acute hepatitis. Bridging fibrosis, chronic hepatitis. Okay, piecemeal necrosis is an acute or chronic active hepatitis. So these are the important one-liner you have to remember in case of your hepatobiliary system. Ground glass hepatitis, HBV. Lumping, microvesicular, increased BTR-PT, which is seen in HCV. Central lobular, CVC. Mallory-Hyland, alcoholic hepatitis, Wilson disease, hemochromatosis, HCC. Councilman bodies, yellow fever. Bridging necrosis, acute hepatitis. Okay. Then you have an ovary. Speaking about the ovary, ovarian tumor, where surface epithelial tumor is associated with CA125 and nulliparous, late menopause, old age, you may see. Germ cell tumor, you may see it in the young, unilateral, and you may see in the ovarian follicle. Sex cord stromal tumor, 40 to 45 years of age with the menopausal women, you may see it. Menopausal bleeding, you may associate it with that. And apart from the tumor markers, alpha fetoprotein for hepatocellular carcinoma, CA125 for serous tumor of ovary, PSA or PAP is for prostate cancer, CA15/3 is for breast cancer. Okay, CA15/3 is for breast cancer. Then, apart from that, samoma bodies is seen in serous adenocarcinoma of ovary, and pseudomyxoma peritonitis is seen in mucinous, the malignant variety of your ovary, and endometrial carcinoma, endometrioid tumor, Brenner tumor, you may see what appearance? Coffee bean appearance or mucinous cystadenoma of your ovary. You may see this type of appearance. Okay, coffee bean appearance in Brenner's tumor. Then germ cell tumor, dysgerminoma, tumor marker is LDH or alpha fetoprotein. Yolk sac tumor, Schiller dual bodies, and hyaline globular. Okay, embryological carcinoma, HCG is a tumor marker. HCG is a tumor marker. Then you have a sex cord tumor, granulosa cell tumor, Karl-Exner bodies, and postmenopausal bleeding, and golden yellow colonies. Golden yellow, Karl-Exner, postmenopausal bleeding, it is granulosa cell tumor. Fibroma, Meeks syndrome. Fibroma with ascites and hydrothorax. While hilar cell tumor, hilar cells are Reinke crystals will be there. Reinke crystals will be there. Now, speaking about that, bone tumor, you have this epiphysis, metaphysis, and diaphysis. Bone tumors are pretty important. So, epiphyseal bone tumors are chondroblastoma, GCT, osteochondroma, and osteoclastoma. While X-ray shows soap bubble appearance in osteoclastoma. Chondroblastoma, you may see chicken wire calcification or chicken fence calcification. Ewing sarcoma, you may see onion peel appearance and pseudo rosette. Okay, onion peel appearance and pseudo rosette. Most common benign tumor is osteochondroma. Most common benign true bone tumor is your osteoma. Most common malignant is your secondaries. And most common primary malignant bone tumor is your multiple myeloma. Most common tumor of your spine is metastasis. Most common benign tumor is hemangioma. Most common benign tumor is hemangioma. So with this, we have completed our systemic ones. With this, we have completed our systemic pathology. So with this, we have completed our entire pathology, people. Among that, general pathology, anemia, leukemia, lymphoma, definitely one question. Systemic pathology, we discussed only the highlights. Systemic pathology, what we have discussed only the highlights. Okay, so far we have done the pathology. You kindly review it, and tomorrow when you are coming, just give a glance about that, and then we will discuss a few things. And then we will discuss the few things about the pathology for 10 minutes, and then we move on to microbiology. And as I said, pathology is one of the hidden giant people. You may expect to see 30 to 40 questions in pathology if you know your pathology very good. Okay, you may expect to see for 30 to 40 questions in FMGE if your pathology is very good. So make sure your pathology is very good and you mastered it. Okay. So this is kind of like a very compressive and a very, I understand it is a very intense notes, but you have to remember each and every point of it because it holds a lot of value on the marks. You have to remember it, people. The PDF will be available on the DaVinci's official number, which you can WhatsApp and you can take your PDF so far. Okay. Thank you. Have a nice day, people.